start. Thank you for joining us for this installment of DSM's Lifting the Veil series. As we are gathering, feel free to just pop into the chat and say hello. If you have questions, you can use the chat throughout the hour-long session. But just to start off with, go ahead and tell us why you tuned in. If you are hoping to learn a particular thing, or if you are, I don't know, fans of any of the panelists, the expert guests, just say hello on the chat, and just to get a little practice. So throughout the session, our team here at BPC will be monitoring the chat, and we'll be funneling any of your questions my way so we can fold that into the discussion. So thank you for joining us. We have a lot to cover, so I want to jump in and start by thanking our sponsors, without whom we could not do this. My name is Michael Moraine. I edit DSM Magazine for Business Publication Corporation. And I am really delighted to be here for this discussion. We've been planning it for several months, and I'm really eager to jump into the conversation. First, our Lifting the Veil series would not be possible without the support of our presenting sponsor, Clive Behavioral Health. And joining us today, if you are a regular in this series, you know him already. He is the Director of Business Development, Jason Bridey. Hello, Jason.
Hello, Michael. Thank you. Yes, thank you for giving us a bit of time here to just quickly say a few words. We are a proud presenting sponsor. We have been for, I believe, the entirety of this series for the last number of years. So again, we continue to do that, and we're proud to do so. Let me give you a quick rundown of Clive Behavioral Health and who we are, what we are, for those of you who may not know. Clive Behavioral Health provides compassionate care for individuals who really struggle with behavioral health disorders or co-occurring disorders. Based on clinical assessments that we do, each patient's treatment plan is always customized to meet their specific needs and promote better outcomes for them. Our mission here is to help patients stabilize behavior and emotions and to leave the hospital with new, effective coping methods. To promote ongoing progress after a patient leaves our care, we initiate community referrals for continued care after discharge. Now, Clive Behavioral Health, just so you all know, we are a 100-bed licensed mental health hospital based in Clive, Iowa. We opened in February of 2021, so we're just a little over 3 years in operation. Key to this is we are open 24 hours a day, 7 days a week, offering both acute inpatient and outpatient group treatment and care. One of the things we always want to share with everyone is that we offer no-cost level of care assessments for anyone who comes to us feeling they need mental health care. That could be folks that are in crisis or otherwise. And for the outpatient side, the programming that we offer, I want to just quickly speak to that. We offer a 4-week partial hospitalization day program for teens. We also offer a similar outpatient program for adults. And then finally, in addition, on the substance use disorder side of things, we do offer an outpatient addiction recovery program for adults Monday through Friday, and that's about a 4 to 6 week program. So we do try to cover a lot of ground and offer a lot of different unique service offerings for folks. We just want people to know that if they do feel that they're in crisis or they know someone in crisis, please consider us. Our doors are open. Our providers and clinicians are here to help, and we just want to make sure that we are that mental health resource in the area and the community that can be relied upon. So thanks again to all of you who have tuned in, and Michael, I will kick it back to you.
Thank you, Jason, and please pass along our appreciation to your colleagues at Clive Behavioral Health. This year, we also have a new presenting sponsor. Wellaby is here, and representing them is Chief Marketing Officer Debbie DeCamp. Hello, Debbie.
Hello, everyone. Good afternoon. For those of you who aren't familiar with Wellaby, we're a new name, but we're not a new company. We were founded 95 years ago as American Republic Insurance Company right here in Des Moines. And over the years, we've seen significant growth and change. And just about a year ago, we rebranded our entire organization under our new name, Wellaby, to better reflect who we are and what we do. And at Wellaby, we like to say, we believe we should do more, worry less, and make every day better. Since 1929, we've provided health and financial solutions to help people protect their health and financial well-being. And so every day we show we care through our shared values, doing what's right, and helping people be well so they can prepare for tomorrow and live better today. And that's exactly why we're sponsoring the Lifting the Veil ongoing series. We think it's a great event. And I want to thank DSM Magazine for bringing us all together today, as well as our panelists for sharing their expertise, and all of you for joining us to learn about such an important topic. Thank you.
Thank you, Debbie, and thank you, Wellaby. I also want to give just a quick shout out to a supporting sponsor, Easter Seals, who has done all kinds of good work in Central Iowa for years and years. So if you see somebody from Easter Seals, be sure to thank them. So we're going to jump right into it. We have a really great lineup of expert guests here. So we're just going to start with Ryan Crane. He's the executive director of the Iowa branch of the National Association for Mental Illness. Ryan, you can correct me if I'm wrong, but why don't we go ahead and start? I'll just do a round robin, just quickly introduce the panelists, and then Ryan, we will start with you. You'll get the first crack at the first question. So after Ryan, we have Joshua Larson, who is a video game developer and the founder of Numinous Games. We also have John Lensing, the CEO of Open Loop. And rounding out the panel is Dr. Sierra Lewis, the director of the Student Counseling Center at Des Moines University. So as you can imagine, all four of these panelists have different perspectives about mental health and technology. So our first question for Ryan, and we'll just go right down the line, is how are you using new technology in mental health care? And how has that changed in the last 5 years? I think it's worth noting that we are all here on Zoom, and it feels very comfortable. You can hear my voice, you can see my pretty face. And that is something that many of us, me included, did not know how to do even 5 years ago. So just help us understand how you and your colleagues and the experts you work with are thinking about technology in ways that are different than even 5 years ago. Ryan, you're up.
Yeah, thank you, Michael. I feel reasonably confident in saying that almost no one would have taken a Zoom call with a therapist 5 years ago. So we'll start there. We being, all 320 million Americans who have, family that don't live in town or whose jobs required Zoom in the last few years because of the pandemic. But oh my gosh, the learning that has been accelerated with some combination of it being more okay to talk about mental health, some of these digital options being extended, and then people suffering from mental health challenges during the pandemic. Many people, myself included, had either some of their first bouts with anxiety, depression, isolation, or had some of their worst bouts in that regard. And anything was better than nothing in those times. A lot of people did turn to telehealth and telepsychology. AI specifically, I may talk a little bit about AI on a more granular level in one of the upcoming questions you have for us, Michael. So I'll yield back for now.
All right, thank you, Ryan. Joshua, you're up.
Hi, yeah. So I'd say there's kind of two parts to my journey with that. The first is through the work that I've done creating video games. At first, it was for just art, but the experience was a memorial about struggling with cancer, and it was ended up using healthcare staff, doctors, nurses, and some mental health care professionals have used it for empathy training to improve bedside manner and stuff like that. And then Numinous, we ended up creating more experiences, partnering with healthcare, including Novartis, to help connect kids who have severe limited motor function with their families, and create a game that they can play with just one button and play along with their family to foster connection and to deepen their relationships. So that's kind of the older history. In the last couple of years, I myself personally struggled with depression for the first time. I'm naturally like a content person, so it's very unusual. But through that, I got really into AI image generation, and that kind of helped me almost like as an art therapy practice, to just be creative again, because I'm a very creative person. That's part of my background, and so I was using those tools to just help like reignite my creative drive, in addition to working with a therapist and exercising more and other tools.
Thank you, Joshua. I will tell the group that I discovered Joshua through just a basic Google search. There was a wonderful Wired magazine article several years ago that talked about how Joshua used or was thinking about using video games for beyond their usual purposes. So thinking about video games to help people with neurodivergence or develop more empathy. So as soon as I read that article and realized he was within striking distance in central Iowa, that was great. John, say hello and tell us how you're certainly, your last 5 years is very different.
Pleasure to meet everybody. It's great to be here today. Just a quick 30 seconds on what we do so everybody knows. We do white label telehealth for a lot of different sorts of companies looking to offer telehealth or digital health services. So we partner with everybody from actual just telehealth companies that want to outsource all their clinical operations, all the way to retailers like Hy-Vee, Publix, Vitamin Shop, to see their consumers and help drive better health outcomes for the consumers walking through their doors. So we supply all the technology, the actual video systems, the electronic health record, all those pieces to run digital health, as well as the clinicians to see the patients, and then all the compliance and billing pieces as well. We are actually a pandemic born company, so started early 2020, different space, but then ended up pivoting within the first couple of months into the telehealth sector, and haven't looked back since then. So our existence, I guess, has been defined by technology within healthcare, particularly within the mental health space. It's been interesting just watching the past 5 years evolve. First, you started to see just therapy visits being conducted via Zoom. That was the immediate transition over. Then you started seeing, okay, how do we get psychiatry and prescribers involved in as well? And that became more, Zoom visits, 15, 20, 30-minute visits that ended in a prescription sent to a patient's local pharmacy. But now there's this sort of new mix that we're noticing, telehealth 2.0 within the mental and behavioral health space. And it's taken the best things of, what I just mentioned, the early stage telehealth portion of these video visits, the convenience of it, the accessibility of it, and now marrying it with what we would call wraparound care. So all the support pieces, we have clients that we power that have brought in AI companions that sort of check in with patients on a daily basis, where the therapist might only be there with them for an hour every week. These AI companions are checking in, every few hours. Hey, how are you feeling right now? Did this work out for you? Did you try, this new tactic that you discussed in your last session? It's pulling down stuff from the care plans of the therapist, and then kind of bringing that back into the daily living of these patients. So that's been really cool to see. I saw somebody drop in the chat, like spaces, tech spaces. The way we see this sort of manifest already with some of our partners is they've really destigmatized the mental health aspect of their consumer base or the patient base within their program, and then got up to a point now where they have almost like communal forums where they're discussing like, hey, I'm really struggling this week, and other people can jump in and provide that. So it's almost like that wraparound care again, except supported by a community. And as everybody knows, the old adage is that shame only exists in isolation. So if you're able to spread that out across a community of peers, it's been really beneficial, and watching the progression of a lot of these patients. But just a couple of quick examples.
Thank you, John. That sets the stage for several questions that we're going to jump into later. So I appreciate that. Sierra, tell us how you're thinking about technology in healthcare education.
Sure. Hi, everyone. Thanks for the opportunity to be here today. Here at the Student Counseling Center, probably the biggest technology that we've implemented is the telehealth platform that we started during the pandemic. And that was received really well by students. It's interesting, though, that in the last several years, I think we've seen a strong preference for in-person services again. So there's maybe a little bit of post-pandemic trauma related to everything having been virtual. So a lot of our students prefer the in-person appointments, but it's been a really helpful option for our students who might be rotating all over the state to still be able to receive services and to be able to connect. So we aren't currently using anything in the AI area, but on a personal note, just as a psychologist, I think AI definitely has the potential to have some really positive mental health impacts, but also poses some pretty significant risks too, which of course we'll get into. So we all pause there.
That's right. And already several themes are emerging. I think we all recognize that mental health care is intrinsically human. Nobody is advocating to just outsource mental health care to the robots tomorrow and they'll take care of it. But I think you all are touching on good questions about how do we blend the tools. We have these powerful high-tech tools to keep us connected in new and possibly better ways than ever before. But how do we create guardrails so it's safe and reliable and effective and ethical? So that's where I think it really the conversation gets really interesting, because there's some murky gray area that I hope the rest of you can, the panel can sort of help us sort out, or at least start to think about how we navigate that. So John, I wanted to circle back to something, since you kind of gave a broad overview of open loop. I want you to just open up the discussion about how telehealth and how new technology can open up access to more people, either in rural areas or people who don't have, especially in Iowa, where our numbers of mental health care providers is pretty low. How can some of these new tools create more access to mental health care resources that people could not tap into before?
Yeah, it's a great question. I think we have to look at telehealth in its current form. Where is it best utilized and what does it not get at? Like, what's the strengths and weaknesses of it, right? And the main draw of telehealth is quick accessibility, convenience, and, even more broadly speaking, just meeting patients where they're at. The amount of visits that we conduct with patients where they're, they set their phone down on the passenger seat and they're just talking with somebody on their drive home, or they pop in for a quick 10-15 minute urgent care type visit with one of our providers during their lunch hour in a quick meeting room. It's for us, and what we've seen, it's about patients getting care when otherwise they would delay it because of the hassle of having to go in person. The 30-minute drive to the clinic, the sitting in the waiting room for 20 minutes, the visit there, then having to repeat those on the way out the door, then having to go somewhere else to get their labs. So really for them, it's about convenience and accessibility, which I think ushers in a new era of sort of preventive medicine, right? Because you're not reacting to everything, then you're allowing patients to get more of the on-time care that they need. And then, so if you marry those two ideas together, then you get increased accessibility everywhere. Location, geography. For us, for example, if you were looking at a traditional health system, like if Unity Point wanted to expand to all 50 states, imagine the investment of infrastructure that would take to do that. We can take a telehealth company that's an idea stage, turn them on across all 50 states in the country in the span of about 2 weeks. And so that's immediate benefit to groups or organizations looking to help people that might be across multiple states. There's different coalitions in rural areas that we have partnered with that might consist of like a tri-state region. Boom, can turn it on immediately. It's a very low cost lift to get something implemented. Really, at the end of the day, the only thing a patient needs is a quiet place and internet. And almost everybody has one of these in their pockets right now. This is all you need to be able to do that. So it's made the accessibility just unprecedented, like levels we've never seen before in the past.
Ryan, I'm curious, for you, is NAMI leading the charge for more telehealth expansion and all of that? Like, how does NAMI think about it? And also, are there concerns that this might deepen the digital divide? As John says, most people have a phone, and most people have access to internet. But I imagine your organization wants to catch everybody and make sure that nobody is slipping through the cracks. How does your organization think about this or approach it?
Yeah, it's a good question, Michael, and I think that the investment that Iowa is making in broadband matters. And then those of us who live in the metro areas, our Wi-Fi is kind of taken for granted, but I think that infrastructure is important and still being built. I echo everything John said about time saving. We have an anecdote of a farmer in Iowa who did not want to go to the local I'm not sure if it was a doctor's office or a counselor's office, I don't remember, but he didn't want to go. He didn't want his truck to be seen in the parking lot. And so he would get into his tractor and, similar to what John had said, just sort of talk to his therapist. I'm not even sure he had an iPad in the tractor or anything. I think he was just talking. And so the fact that he can do that now and receive healthcare, I mean, we might look at him as a prototype and make some assumptions about him, but the truth is he figured it out, and he was interested enough in seeking help and open enough to seeking help that he made it work for himself. And I think that telehealth for rural, like I already said, the broadband needs to be built up, but I think it's already working, and I've been encouraged by what I've heard in the field.
It reminds me in the 1980s farm crisis, when so many farmers were just trying to make ends meet, and so many self-reliant, proudly self-sufficient farmers did not want to reach out for help.
Absolutely.
There was a big push for a suicide prevention hotline and a phone number that farmers could call, just to have somebody to talk with. So I think this is, in some ways, we've come light years from that, but in some ways they're still the same issues, especially for rural communities.
Yeah.
Sierra, I want to circle back to what you mentioned about how your students, and these are, I imagine most DMU students are digital natives. They grew up with cell phones. They're very accustomed to technology. But even that generation recognized the value of face-to-face, in-person connections. Do you have any sort of sense of proportions, like what percentage of your counseling sessions are telehealth or remote, and what percentage is in person, or what's your goal? What's your strategy there to find that balance for students who prefer one or the other, or
Sure.
along
I
those
mean,
lines?
yeah, I definitely think that the vast majority is in person now, but it's great to have that virtual option for people that maybe aren't feeling that well, or they're having car trouble, or, again, maybe they're rotating in a different part of the state. So that access to the virtual therapy has been incredibly helpful. It's just, before we were doing that, we were doing phone sessions, which it's so much harder to have a rapport and to, interpret what's going on, even just like talking over the top of each other. So I think that having the virtual option is great. And then there is the preference that a lot of folks have for that in-person connection, a safe space that someone can come and kind of have that holding environment for painful emotions, and then they sort of metaphorically get to leave it behind when they leave that space. So it kind of goes both ways. For some people, coming to a protected, safe environment is very soothing. For some people, doing that from home in their own protected, safe environment is very soothing. So I guess when I think long term down the road, I definitely agree with all of the potential benefits that everyone has mentioned so far. I think one way that access could be potentially reduced in the future by AI is if there are organizations or companies that decide to then use an over reliance on technology based applications, and sort of weigh that argument of, is it more cost effective for us to not have therapists and to eliminate our workforce and instead rely on AI mental health delivery? Could that actually reduce in-person access even more for the people that really do benefit from that one-on-one in-person connection. So I think that would be maybe be a future concern that's certainly further down the road, but could that actually shrink the mental health workforce in some ways?
I think in across every industry, there are sort of tempting time-saving efficiencies that AI can offer, but also in every industry, there's some sensible hesitance. What does that mean for trained professionals, and what do we lose when we reach for efficiency? Since we're talking about AI, since we're heading in that direction, I'm curious, and maybe this next question is for Joshua. In some of the artificial intelligence tools, does it matter if the person using them knows that it's a robot? John mentioned, an AI chat that has prompts throughout the day, which almost makes me think of like a smart journal that, it's still a solo activity, but you have a tool that's asking you questions. Joshua, how do you approach that? When you design video games for people or other software programs or tools, the users know that it's a machine that they're interacting with. How do you think about that?
Yeah, I mean, so I guess first of all, I feel like that's a psychological question because your state of mind, like knowing whether what you're experiencing is actually the reality is important, and that is something that we think a lot about designing games. So like the mental state of the player. Some game designers actually talk about how the games that they make are all in people's heads, and that's where they design, is like within the mind of a person. And so yeah, I think like whether or not somebody knows the truth about what they're interacting with is really important. And there's been some research done on that related to chatbots and language model based AI, where you can just text chat with some kind of agent or something. And so yeah, that is definitely important when it comes to mental health too, I think, just because it does have a psychological impact. But beyond that, I think it's really important to understand how the technology works, as when you're going to create it and try and make it usable and try to ensure that it's a positive experience for as many people as possible. So I'm here at a futurist conference in California, and I met somebody who is working on being able to inspect the inner workings of AI more. So there's been some recent breakthroughs in research that allows you to understand more deeply how the AI works. Up until now, a lot of people think of it as a black box, and that's concerning, especially with something as high stakes as mental health. And so just yesterday, he was in the co-working space with me, working on his development, trying to create software that understands the AI more, and then that allows you to create those safer guardrails. Now, there's still ways to do that now, but it is more indirect. And so what he's working on allows you to more directly set boundaries and more directly control, creating a safe experience for people.
I'll open it up for the group. Are the rest of you experimenting with AI tools, or are your colleagues sort of tinkering with AI tools, just starting to see what's out there and what's available?
Well,
Yeah,
I'll
go
let
ahead,
John
Ryan.
go first, but I wanted to say Joshua had a neat thread, but John is the AI expert. I'll defer back to John for a moment.
Oh, no AI expert here. It's our firm belief that the patient-clinician interaction should never be disrupted or replaced. people long for that empathy that a provider gives. Everybody hates being put through a phone tree when they call customer support, and that's something we don't want to emulate in healthcare. Like, you just want to talk to somebody at the end of the day. Like, that's it, particularly within mental health. And so we've tried to weave AI in every single other area possible for us, and that's in wraparound care and decreasing provider cognitive load, as we would call it. So, for example, a lot of the patients that we see, they will fill in some sort of intake to begin with, right? There's the mental health intake, there's a urgent care sort of intake that they'll fill out, a variety of different sorts of intakes. What we built, though, is AI that will scan sort of their past medical history, scan their intake, and spit out a SOAP note preemptive of a meeting for our clinicians. So one, it provides a very good summary of like most likely reason of what's going on with the patient and why they're back again. And two, it already provides a charting note form with very minimal editing, so decreases documentation time significantly. So that's allowed us to be more efficient with provider schedules, decrease sort of that cognitive load that a provider has to work on. Everything in telehealth that we do has to be very repeatable and scalable. And so a lot of our clinical protocols, more on the prescriptive side of mental health, have been optimized with our AI. And then on our provider scheduling, given the nature of telehealth, and it's the laws and regulations surrounding it, providers have to be licensed in every state of which they're seeing a patient. So you have providers with a multitude of state licenses now that are doing telehealth, but then having to optimize their schedule to create maximal overlap and cover all the patients and geographies that we're serving creates a little bit of headache, and AI has helped accomplish that more efficiently for us. So it's everything that we can do to like maximize the time that a provider has with a patient, with everything else falling to the wayside for them. So that's the way we've done it, try to preserve that provider-patient interaction.
That's a great way to think about it. Give the robots what they're good at and save the stuff that only humans can do. That's a great way to sort of clear out the clutter, especially in a place like Iowa where, you know, mental health providers are rarer than some places. So you want to maximize their human time. Ryan, did you have something?
Yeah, and actually, John built off of that as well. I'm kind of grateful and honored to be on with Josh and John as they talk about some of these things. The idea that telehealth as therapy, I think that in the future, not anytime soon, maybe not even in the next 5 years, but I do see a future, and this is more Ryan Crane, who has been, you know, studying this as kind of a side thing. NAMI, obviously, you know, at a national level, is not talking about chatbots being therapists. You know, like I said, anytime in the next, you know, 6 or 12 months or anything like that. But I do see a horizon out a little further, where, you know, studies that have been evaluating therapy chatbots, or therapeutic virtual environments. Those are two interesting things that we've looked at. Josh got me thinking about tightening the large language model and sort of fine-tuning the large language model so they don't spit out clinically or medically inaccurate stuff, or they don't react inappropriately to a really deep disclosure that somebody gave. So training the large language models and the AI is important before we get to chat therapy or AI therapy, which I do think is coming. And then those virtual reality rooms as well, where there's been some interesting studies about the importance of nonverbal communication in a therapy visit. I'm sure Dr. Lewis would have something to say about that. And currently, all of the chat features and even most of the telehealth features don't really capture that. So there's been some large language, I guess not large language model, maybe Josh can jump in and save me, some kind of nonverbal large language model thing where we are feeding in what does nervousness look like, what does avoidance look like, what does anxiety look like in a human. And we can begin to get pretty good at guessing with the help of a video screen or a teleconference if that person isn't telling us everything. Like I said, this is not 6 or 12 months out, this is far out. But the other piece, and then I'll yield back, the other piece that, in addition to those two kind of exciting futuristic nuggets, the one that's a little more practical and is getting a little bit more, I guess you could say, traction, is the opting in of people to allow themselves to be guinea pigs with some of this chat stuff is happening now. Nature magazine actually just released an article in January of this year, and I won't take long with this, but I just wanted to read. The patient prompts and says, I was left out of her will because I followed my dreams. I never really figured out how to deal with that. I guess I'm just moving forward as best I can. And the chatbot responded, I'm sorry to hear that you felt rejected in such an intimate way, especially when you were pursuing what's important to you. That must have been a tough experience. What thoughts come up when you think about this situation? Like, whoa. I mean, that's right. That level of training is already happening with large language models and chatbots. So I do think, even though it sounds kind of dystopian and kind of weird and kind of uncomfortable for us currently, I do see a future where some really highly refined AI type chatbots are providing some kind of therapy. And the reason that I like this, or the reason that that doesn't freak me out and make me go all Orwellian, is because of access. A lot of young people are way more comfortable online than we are. You know, Gen Z is on their phones 6 hours a day, and young men who would not go to a therapy visit or probably even a telehealth visit might give a chatbot a try. And so we think that access could expand, or rather, we think that AI therapy could expand access at some point.
I think that training piece is a really great point, because there is a lot of satisfaction already early on with some of those AI interventions, like being able to help reframe negative thoughts and even doing activity scheduling, kind of that sense of maybe just like companionship or help brainstorming coping activities. So I think there's already some good satisfaction that users are reporting with that. I think the piece that maybe still is really important to consider in the training factor is some of the risk assessment, which so far some of those models are not showing great evidence of them being able to assess whether or not someone is at risk of harm to self or others. And so some of the bots that exist currently don't even actually prompt a user to seek help, even if the person directly names a word like suicide or self-harm. And so I think there's a huge area of risk there and additional training that's going to be so important for this technology to catch up to. And so far, I've not found anything that is doing any kind of a homicidal ideation risk assessment, which of course is also incredibly important. As a licensed professional, I would have a duty to warn if something like that should occur, alerting law enforcement, of course, but then also warning the intended potential victim. And so where does that duty to warn fall with something like AI? So I think there are some really important safety related and risk assessment related areas where that training needs to grow a bit more.
That's a great point, Sierra. In November, in the session coming up in November, one of the panelists works with Des Moines Public Schools, and she told me about their tool, and it was new to me, where there's a AI monitor that checks that scans all the keywords that are punched into school devices. So if a student types in, how many pills would it take to accomplish XYZ, that flags to one of the school guidance counselors who can follow up with that student and say, was that just for a research paper, or would you like to talk to somebody about it? So it's a little bit of Big Brother watching, but it's paired with a human who can follow up because of that risk assessment, because you want to err on the side of safety. So I don't know, Ryan.
Yeah, I was just going to say one last word on that about the schools, Dr. Lewis. Many of younger people are now with their openness of mental health. It does have a darker side at times where they have now started introducing acronyms and they have started introducing codes that they use. KMS is code for kill myself, for example. And so I don't suppose a lot of parents know that one, but AI would spot it in a heartbeat. And that is the kind of intervention that we would be happy to see.
Yeah, and it's interesting too, because there definitely could be opportunities for an AI chat, platform to be able to provide people with, crisis numbers or even help people set up with referral agencies. And so I think that would be a helpful direction to go in. And right now, it just looks a little bit imperfect. I was reading one study where even after making those recommendations to seek additional care or seek a higher level of care or emergency services, sometimes the app then would just shut down and stop interacting with the user completely, which of course could be a really isolating feeling for that person. Or they also found the opposite, where if someone kept engaging with the app, it would just start the dialogue over again. And so then that area of risk or that referral for in-person services would sort of potentially fall to the wayside. So yeah, all kinds of opportunities for growth there and necessary growth there.
Well,
Yeah.
while we're speaking about young people, I want to fold in a great question from Rhonda in the chat. And this goes back to, well, training and also telehealth options, telehealth tools. She's really interested in the concept of power balance and creating safe spaces, especially for youth and young adults. And she mentioned the example of the farmer with the issue of the issue of potential stigma going to a doctor's office, and there's that power imbalance, and if a farmer or whoever may not feel comfortable in a doctor's office. And this is a question for anybody, has there been any talk about a shift in trust and equity in mental health discussions when conducted virtually? Are you working with therapists who are training to do their job differently when it is virtual or remote, when they can't read body language or their limitations because of remote tools? Does that make sense? It's a great question. It's fair game for the group if anybody wants to jump in.
I think maybe it takes more intentionality. I think when I meet with folks for the first time virtually, I'll give a lot of descriptions about if it's our first meeting and we're doing if I'm gathering a lot of information, I'll give that person a heads up that they might notice that I look away from the camera and the reason why and sort of what I'm doing. So I think I try to explain some of the behaviors that someone might see from me so that they also know how to interpret that. And you've noticed I've become a lot more of a hand talker too, knowing that someone only has this tiny, screen version of me. I think it's definitely made me a little bit more expressive so that it's easier for someone maybe to pick up on my nonverbals.
John, did you have something?
Let's say, we've actually had our providers, this is a provider initiated movement with us, that over the course of doing telehealth now for 5 years, they've come upon some of the standard operating procedure, if you will, with patients. And they'll always ask them that at the beginning of the visit, like, do what's comfortable for you. Like, if you don't want to keep holding your phone, if you don't want to be looking at your laptop, turn it away, put your phone against, like, stand it up against the wall so it's still facing you or whatever. Go sit down on your couch, take a comfy chair, whatever. And then the provider themselves will also ask, like, where would you like me seated today? Like, do you want to, like, is this an in-depth conversation, a deep one today where you want me right up on the screen and front and center? Do you want me more comfortable, relaxed? So it's more of just an interaction. And, that varies week to week, even with the same patient. It's interesting to see, right? Sometimes like, this week's actually really good. Sit back and let's chat as friends in many ways. Versus like, no, I need some, it's been a horrible week. We need some serious talk.
Mm-hmm.
So I think giving patients that optionality gives them a little bit more control back in that power dynamic. And I think that dynamic, like you mentioned, Rhonda, is already diminished in a telehealth setting. Sierra, to your earlier point, it was intriguing about how some students want to come back into in-person world. I'm not saying this is the case with you, but something that might be interesting, just an anecdote. We worked with this telehealth company that had been going to universities and signing them up as their telehealth partner. And during the pandemic, when students were home, back home with their parents, loved the virtual aspect, kept doing it when school started back up again, but then started slowly returning to in-person work. And they had no idea why. And then they dug in and started interviewing a bunch of students. And the students said, well, as much as I don't like going in person, because I got to walk across there, the convenience aspect, like, the only place for me to take these calls is my dorm room, which my roommate is there, or back in my house where all my other roommates are at. And I'd rather not have them overhear the conversation that I'm having. So, you know, it's interesting. They're choosing, like in this case, they were choosing, you know, more of the traditional, something that they thought was more convenient just because of the stigma of it all.
I guess one theme that I hear emerging is with technology comes more options, but that doesn't mean you have to abandon the traditional one because there's some good things there. Because people are different and because people are complex, the bigger the menu, the more likely it is that people can find something that fits for their preferences and how they are comfortable. So I guess that we're heading in the right direction, but it also can be overwhelming too. I mean, if there's so many options, like where do you even start?
I have a
We're in the
question.
home stretch, but Joshua, do you want to weigh in?
Yeah, I had a question for Dr. Lewis actually, because I heard that Roosevelt has a phone ban now, Roosevelt High School, and it's part of a broader movement in youth to kind of reject the control that they feel that social media has over their lives and how damaging it is for their mental health, at least the way that it's designed now, which is optimizing for people's attention, has many negative side effects. And I was just wondering if you've seen that influence the kind of like mental health care that youth are seeking. Like, does it seem like they're intentionally trying to like push away from virtual interaction from that perspective, or is it more just like about convenience or whatever? It's just something I've thought about a lot in the last couple of weeks, because I didn't realize that that they were being so intentional about, you know, like trying to carefully craft their digital interactions in order to like try and improve their own mental health. I just like think that's really interesting.
Yeah, that's really cool. I think for so many people, it seems like phone use is something that creates almost an inner conflict. I think most people kind of recognize, like, I'm spending too much time. This isn't great for me. I think there's even a lot of that revenge procrastination that happens where people are just up on their phones late at night, even though what they're doing isn't all that enjoyable or relaxing. But it's almost like, here's my opportunity to use this. And as you mentioned, I mean, so much out there is sort of designed to really give a lot of those good dopamine hits to make sure that people are using it over and over and over again. So I think that a lot of people do have a desire to reduce their usage, but it's just a lot harder than it seems. I mean, I think that it's something that's easy to say, but yet is hard to actually enact in practice when so much of our lives is dependent on that technology. So I guess that would be another potential concern, is would there be some users that would maybe have an over reliance on some of these mental health apps and then stop taking the chance to seek out in-person connections with their peers or with their family members or potential romantic partners. So I think we also want to make sure that, yeah, we're encouraging people, and some of the apps do this, you know, might encourage people to do in-person experiments with, oh, what if you met someone in your class that also has an interest in hiking or whatever. So yeah, I think that it's sort of a mixed bag for a lot of people.
This is fascinating. This conversation is as juicy as I hoped it would be, and I already am curious about lots of other things. We just in the interest of time, I want to sort of bring us around. Each panelist, I will give you the last word. So think about if there was one surprise or something you want to emphasize from this discussion. Think about your takeaway, because I'll give you the last word. But until then, just again, thank you to our sponsors from Clive Behavioral Health and Wellaby. We really, really appreciate your support. Same goes for Easter Seals of Iowa, our supporting sponsor. As I said at the top of the hour, we could not do that. We could not do this and have these rich discussions without your support. So thank you very, very much. One heads up for the group, for the greater good, we have some upcoming events with DSM Magazine. If you have never come to one of our parties to release our next issue of DSM Magazine, they're really fun. I encourage you to join us June 25th at Destination Grill in Grimes. And then the following issue, already we're thinking about September, October, we will unveil that issue at Edgewater on August 27th. And then the next virtual panel in our series like this, in the Lifting the Veil series, will be November 19th. And that will include a mix of, it will probably have a more clinical focus. We'll speak with some direct therapists from Broadlawns Medical Center, Ellie Mental Health, Good Life Therapy, and as I mentioned before, Des Moines Public Schools. So we will keep this conversation going and continue the discussion because as you heard right here, there's plenty to discuss. As always, if you would like to subscribe to DSM Magazine, you sure can. You can find the details at dsmmagazine.com, as well as our sibling statewide publication, IA Magazine, an annual issue. If you have story ideas, I welcome them. Fling them my way. You can email me at that address that's listed on your screen. And we always welcome advertisers. So if you would like to advertise, Chris Cohen would love to hear from you at the email address that's marked there. All right. The next, also I should mention that these virtual discussions coincide with an annual publication called Lifting the Veil. The next issue is coming out this winter. So you can access, if you go to dsmmagazine.com, you can find out how to get, you can see a full virtual copy of the current issue and see how to get a print copy. Otherwise, keep an eye out for this winter when we will release our next printed edition. So with that, I want to give, as I mentioned, I want to give the panelists the last word. Well, why don't we go in reverse order? We started with Ryan. So Sierra, why don't you send us off with some closing wisdom?
No pressure. I think that for me, I guess my takeaway would be there's so much good, so much potential good that these platforms can offer. And it's important that we walk before we run. So I think making sure that it's done thoughtfully and that it's evidence-based and that there's all kinds of, as was mentioned earlier, just some guardrails, and to make sure that this is a truly safe and healing experience for people is so critically important. So I think just maybe being sort of measured and cautious and doing our due diligence to bring all of these wonderful applications forward.
Thank you so much, Sierra. Those DMU students are lucky to have you working with them.
Thank you.
Joshua, why don't you take a turn?
Sure, yeah. I just really love, John, how you put, like, let's use these tools for what they're good at. Let's involve humans for what we're good at. That's one of my big takeaways. For me, what that means is just thinking about like how to design technology for our wellness instead of only thinking about profit or only thinking about optimizing it for our attention. Obviously, we want it to be engaging. Obviously, we need a level of success in order to increase access and improve the effectiveness of these tools and stuff like that. But yeah, just trying to think of things in terms of how can we intentionally make people well, and yeah, I think there is a lot of potential and a lot of ways that we can use it throughout our lives.
Thank you so much, Joshua. And enjoy your time in California, peeking into the future, and keep in touch. Let us know how it goes. John, why don't you send us off with a nugget of wisdom?
I think as healthcare providers, we've always said, patient comes first, but in traditional healthcare, oftentimes it's like, yes, patient is what we're trying to work towards, but it's like, you're going to come to our site, you're going to go to this place, you're going to be on our schedule, our time. And there's a paradigm shift now that's rippling through, and with technology, the increased access, the increased convenience, there's this shift now to like, it actually can be patient first. It's like patient choice in a lot of ways. There's optionality on how patients can get their care, how they're going to get their issues addressed, where they're going to get it addressed. And so it's user choice, it's patient choice at the end of the day. And I think technology is only further empowering that, and it's putting the patient's care back in their control. You know, as opposed to like, hey, you have this one health system that's local to you. Everything that you do is going to be driven through that, right? So this optionality is good. I think it'll help meet patients where they want to be met, on like just on time sort of care, just on time at the right time. So I'm really excited about the next 5 to 10 years in the healthcare space. I think pandemic issued in some miraculous innovation, and excited to watch it continue to unfold.
All right. Thank you, John. All right, Ryan, you, no pressure, but you're going to send us off.
Yeah, Anami, evidence-based, shout out to Dr. Lewis. Optimism, shout out to John. Josh talking about how the technology will always need a human touch. I agree with that. There's help and hope. That's what we say at NAMI. And I know that almost none of us 15 years ago could have imagined, you know, having the internet in our pockets 24/7. And that probably would have freaked a lot of people out. But I think we could pretty, you know, comfortably say that cell phones net have made our lives better. And I think that mental health could have some similar quantum leaps in the next 10, 15 years. And it's maybe a little weird to think about a chatbot therapist right now, but that's only because we haven't rolled it out and tested it with 10,000 people yet, you know? And so I think that we'll have a ton of insights in future years that we can't even imagine right now. And that's where I'm hopeful and optimistic and forward looking.
Thank you, Ryan. Well said. And really, thank you to all the panelists. There's so much to unpack here. So I appreciate your willingness to just fling yourselves into a freewheeling discussion. However it evolves in the next few years, DSM and Business Publications Corporation will cover it. We will continue this important conversation. Thank you all to everyone who has tuned in. If you are here, that means you registered, which also means you'll get a recap email. And that'll have links to a recording and various ways to keep in touch and to tune in to the next iteration. We will leave you with a screen. We have one more slide that's a list of useful resources. And as always, our collective knowledge is only as good as the community. So if you have suggestions of resources that we should share or other tools that you think other people could find helpful, please let us know. We would love to hear from you. So thank you for tuning in, and we will see you soon. Take care.